Hi guys, this is the lecture on basic dysrhythmias. What I am hoping that you will do with this is listen to this. If this is the first time you have ever seen any rhythm strips, it will seem very confusing in the beginning, but the more we go over it and practice, the better you're going to become and understand it. So my goal is for you to listen through this at home, and then we come into class, I will highlight each of the different types of rhythms and dysrhythmias, and then we will practice. So hopefully at the end of this, you will have a better understanding of basic dysrhythmias. Some of the need to know include basic understanding of the conduction system, identify placement of the ECG electrodes, understand the parts of an ECG waveform, comprehend basic steps for rhythm interpretation. We're going to go over ECG rhythm strips to identify normal sinus rhythm, sinus brady, sinus tach, first, second, and third degree blocks, V-tach and V-fib, and also asystole. And understand what may cause each of the dysrhythmias and nursing interventions. So first, real basic, this should be a review of your pathophysiology, but the cardiac electrophysiology, we have the electric cells, which are your conductive cells. These are specialized cells within the heart, which can discharge an electrical current. This will initiate the beat, and when this beat is initiated, this property is called automaticity. This will initiate electrical activity, which tells your heart to beat, and conduct it through the heart. So that is your electric conductive cells. So again, there's specialized cells within the heart that will discharge an electrical current. Mechanical, which is your contracting cells, this is the actual contraction of your heart, respond to the electrical stimulation and contract to pump blood through your body. The mechanical beating or contraction of the heart, which is the contractility, is the mechanical property of this. So a person will have both a heart rate and a blood pressure with the electrical and mechanical properties. These two components must occur for the heart to be able to contract and pump blood. If you don't have both of them, you will not be perfusing blood throughout your body. Cellular depolarization. The interior cell becomes positively charged and the cardiac cell will contract due to the movement of your sodium and potassium across the cell membrane. So then there's potassium outside and sodium inside. So that's cellular depolarization. Cellular repolarization is the resting cell, which is repolarizing, and the potassium and sodium return back to how it was. So the potassium is mostly on the inside, while the sodium is mostly on the outside. And this also is your resting phase. So you're going to understand a little bit when you're looking at ECGs if you're depolarizing or repolarizing. With the conduction system, these are specialized electrical cells in the heart. They're arranged in a system of pathways called a conduction system. These specialized electrical cells and structures guide the wave of myocardial depolarization. So remember, depolarization is when the cell will contract, and that's when the potassium moves to the outside and sodium on the inside of the cell. There is the physical layout of the conduction system. So you've got your sinoatrial node, which is your SA node, your atrial ventricular node, or the AV node, your bundle of His, which is also referred to as the AV junction. Then you have right and left bundle branches, and Purkinje fibers. This here is just a diagram of the basic conduction system in the heart. So you can see on top the SA node, which is up in your right atrium, will travel down to your AV node, which is between your right atrium and right ventricle. The AV node then will go down into the bundle of His, which is also the AV junction, and it will split into your right and left bundle branches, and then you'll see further splitting that goes into the Purkinje fibers on either side of the heart. So your sinoatrial node, or SA node. Again, this is located in the posterior wall of the right atrium. This is known as the primary pacemaker of the heart. It has the greatest automaticity that's located up in that SA node. It will normally fire at a rate of 60 to 100 beats per minute. There is something called an atrial kick that occurs when the atria contract. 30% of the cardiac output will go into those ventricles. It's important toward maintaining our blood pressure, so you need to have a good atrial kick. So just remember, SA node is your primary pacemaker node of the heart, and it is again between 60 to 100 beats per minute. So hopefully all of us, as we're sitting here listening to this lecture, your SA node's firing good and you are somewhere between that 60 to 100 beats per minute. After the SA node, it moves down into your atrial ventricular node, or AV junction. This is located in the lower portion of the right atrium above the base of your tricuspid valve. This will delay and relay impulses to the ventricles. This is kind of the pathway from your atrium, your right atrium, to your ventricles. It then goes down to the bundle of His and Purkinje fibers. The bundle of His and right and left bundle branches, also known as the AV junction, is located in the upper portion of the interventricular septum, and they have pacemaker cells in there also. But these pacemaker cells are capable of discharging at an intrinsic rate of 40 to 60 beats per minute. So this is a backup function for our heart. So if for some reason our SA node is not firing properly and we're not conducting it through the heart, through the atrium, it will then travel down to your AV junction. And again, that will fire between 40 to 60 beats per minute. If that does not work, it goes further on down through your Purkinje fibers, which are the terminal ends of the bundle branches. This is the third and final pacemaker site, and they will pace at a rate of 20 to 40 beats per minute. Okay, for most of us, 20 to 40 beats per minute is very bradycardic. It's very slow, so your patients will probably be symptomatic at this point. This is where we get to look into some different types of blocks, especially that third degree block that I'll talk about a little bit later. So this here is just a summary of the pacemaker function of the heart. So you guys can look this over, but again, we got level 1, 2, and 3, your normal backup system and lowest backup system. Again, ultimately, we want our SA node to be firing regularly, because then you're going to be having the primary pacemaker of the heart between 60 to 100 beats per minute. Okay, so an electrocardiogram, it is also referred to as an ECG. You'll hear many people call it an EKG. I honestly don't know where the K came from, but actually you'll probably hear more EKG than ECG. But anyway you hear about it, it's the same thing. And the ECG tracing is designed to give a graphic display of the electrical activity in the heart. The ECG cannot tell you about the mechanical activity of the heart. To do that, you need to assess your client's blood pressure and pulse. Okay, so this is just looking at the electrical activity. So you could have somebody, and these are rhythms you're not going to go through today, but you will look like you have a rhythm on the monitor, but your patient's heart is not actually beating. It's because the electrical activity is still firing, but there's no contraction, there's no mechanical activity going. So that's why you always want to assess your client's blood pressure and pulse and make sure they have a pulse. Moving on here, the monitoring system typically has a 3-lead or a 5-lead system. We even have 7 leads, then we have our whole 12-lead EKG. But just for you today, general, we have a 3-lead system here, and they are color-coded cables. So this is a universal color again. So if you commit this to memory, then if you see any 3-lead ECGs, then you can know where they're supposed to go, a placement on your patient. The negative lead is usually white, the positive lead is red, and the ground lead is black, green, or brown. So you have a negative lead, a positive lead, and a grounded lead. the leads record each of the electrical activity between two electrodes. So each lead has a positive and a negative electrode, and the placement of the electrodes will allow you to see a single view of the electrical pattern of the heart. So what does that mean? Depending on where you have those positive and negative electrodes placed on the chest, on the lower or upper extremities, wherever they are placed, you're going to look at a certain angle of that heart, and then that's where you're going to see your ECG come up with a certain rhythm. So you do need to make sure that these are correctly placed. And there is different leads that you can look in to get different angles of the heart. But right now we're going to be working off of just lead 2, which is your universal lead when you're just looking at a basic ECG rhythm. The electrodes are adhesive pads that contain a conductive gel and are attached to your client's skin. And there is a picture of one here on the slide, and you can see it's just a round like sticker, and on the other side there is like a gel-like substance. There are other types of electrodes. Some of them look like little tabs, and there is like the conductive gel just on the end of the little tab. But for whatever it is, you do want to make sure there's good skin contact and adequate conductive jelly in the center of the electrode. So that being said, if you have a client that comes in that's like really sweaty, or maybe they were out working in the garden and you think they come in having chest pain, if they're dirty, you need to make sure that their skin is clean. And so that way you will have good conduction through that lead. So you may have to take the time to grab one of those wipes that we use for the bed baths and wipe their chest off. If they're very diaphoretic, sometimes it's hard for them to stick. So again, we may need to try to clean them to get those to adhere as best possible. If you have a male that has got a very hairy chest, it's important that you take clippers and clip the area where you're going to put those stickers. Because if you put those stickers just on a bed of hair, you are not going to get good conduction through that. And again, we don't shave, right? Because if we shave, you may nick the skin, and we got other potential problems with that there. So just remember, if they have a hairy chest, we need to clip the areas and then put the leads out. So take the time to do this. It may seem like a hassle at the moment, but you're going to have more of a hassle trying to get those leads to conduct and to give you a good rhythm if you try to go the fast way and just put them on top of this hairy chest. Okay, I'm done with that. So, color-coded ECG cables. Lead 2, like I said, is our universal lead that we will be looking at all our rhythm strips in. Lead 2 records the difference in electrical potential between the left pectoral muscle and the right clavicle electrodes. So you can look on this picture up here of this dude with the lead 2 placement. Lead 2 views the inferior surface of the left ventricle. This lead is commonly used for cardiac monitoring because positioning of the positive and negative electrodes in the heart lead most closely resemble the normal pathway of current flow in the heart. Okay, so for your lead 2, and really for most things for you, unless you get really involved in cardiac, if you have a 3-lead ECG monitoring, this is how they're going to put. So the positive is red, and you can see that is below the left pectoral muscle, and a negative lead is white, which is below the right clavicle. This is a recommended lead also if we have to do cardioversion. You guys probably don't know what cardioversion is, but for some dysrhythmias, we may have to actually shock the heart to get it into a more perfusing rhythm. But that's for, I think, 3rd semester, you do that. But anyways, it's recommended lead 2 for electrical cardioversion due to the large upright deflection. Because when they're shocking the heart with this in lead 2, it'll start lower and go up through the heart to the right side. So it kind of gets the best deflection to kind of shock that heart back into a good rhythm. So a popular phrase for lead 2 is smoke over fire. So if you look at there, the red lead is your fire, and then when there's fire, there's smoke. So your black would be above your red. So smoke over fire, and then white is on your right. So just remember, white on the right, smoke over fire, and you will always remember how to place these leads. This EKG paper or ECG paper is graph paper that is made up of small and larger heavy lined squares. The 5 small squares between the heavier lines prints at a constant and standardized speed in an ECG printer. Each small square represents 0.04 seconds. So if you look at this diagram here, you'll see on the bottom it says there's 3 seconds in the red there. If you look at every single tiny square in there, each of those are 0.04 seconds. Okay, and that is something you will need to memorize. And if you look at the right, that is one of the big squares that's blown up for you to see it better, and it's 0.04 seconds for every little small box that you see there. Each larger square represents 0.2 seconds. When you think about it, if you count those small boxes in one large box, there's 1, 2, 3, 4, 5. 5 times 0.04 is 0.20 seconds. Okay, so you just, again, make sure you know that each small box is 0.04, each large box is 0.20 seconds. It's standard practice when we print out a strip, they are of 6-second durations. So if you look on the strip here, you see on the bottom where it says 3 seconds, you see those little lines that are sticking down. So really, you would have to count another 1, 2, 3, 4 of those to get a 6-second strip. But for all intents and purposes, for us while we're practicing on your exams, everything will be a 6-second strip. Okay, so there's no trying to trick you with that. We're going to interpret stuff on 6-second strips. So anyways, we practice with strips of 6-second duration because then it's kind of easy to figure out how fast your heart is beating. So to determine ventricular rate, you will multiply how many QRS complexes are in a 6-second strip times 10. So I'm going to show you some strips here in a minute. This probably doesn't make much sense, but when we know what the QRS is, let's say we count 4 QRS waves in a 6-second strip. If we have 4 QRS waves times 10, that would be 40. So again, that's just an estimate, but that gives us a decent idea about how fast that heart is beating. Okay, so anyways, this is also called a rule of 10, which is the quickest way to use a rate of measurement, but it's really considered the most inaccurate, but for all intents and purposes, it gives us a decent understanding of how fast the heart is beating. For beginning interpretation, this is fine. I believe Yvette will teach you the counting method, which is a little bit more complex, but again, your heads are going to be kind of full with all of this stuff right now, so I just want to give you the easiest way to go at this point. Okay, so here's our ECG waveforms. The P wave is when the electrical impulses originate in the SA node. So remember, that's on the right atrium of your heart. The P wave is indicative of atrial depolarization. So when you have depolarization, that means that P wave is when the atrial will contract. So it's squeezing, okay? Then a PR interval will extend from the beginning of your P wave, which is your atrial depolarization, to the onset of the QRS complex, which is your ventricular depolarization, which that's when it travels through your AV node. So your P wave, as you can see there, is atrial contraction, your QRS is ventricular contraction, and those are both depolarization. The PR interval is measured from the beginning of the P wave to the beginning of the Q wave. Okay, we're going to do this in class, so I'm not so worried about you understanding this so much right now, because I think once you have it in front of you and you're physically doing it, it will all come together. Okay, so you should not, okay, so for a PR interval in normal circumstances for a normal ECG rhythm, it should not exceed greater than 0.2 seconds. Okay, so when you are measuring your P wave to your QRS, they should be equal to or less than 0.2 seconds. That is your normal PR interval. Okay, so that is something also you need to memorize. This will be important in identification of heart blocks, which will be going over a little later. So then we move on to the QRS complex. This again is your ventricular depolarization, so that's your ventricle contracting. There's a large complex of 3 waves, the Q, the R, and the S, as you can see on this diagram here. Each QRS complex can look a little bit different. Regardless, they are always generically called the QRS. Okay, that's what we're looking for, a P wave and a QRS wave. The upper limit of normal for a QRS is less than or equal to 0.12 seconds duration. Okay, 0.12 seconds duration is 3 small squares. Remember when we were looking on that, 0.04 is one of those small squares. So your QRS, to be within normal parameters, should be equal or less than 0.12 seconds. And that is something else that you should know. The ST segment begins at the begins at the end of the S complex and ends with the onset of the T wave. This is early part of repolarization of the ventricles. You may not always see a T wave, but that again is the early part of repolarization. So your heart is relaxing for that millisecond before it starts to pump again. And then your T wave is your actual ventricular repolarization. So this slide here on interpretation of ECG rhythms require analysis of waveforms and the interrelations of your P wave, the PR interval, and the QRS complex. So we are looking at rate, rhythm, site of the dominant pacemaker, and configuration of the waveforms. This will require repeated practice. So again, we will do these in class, but you've got your P wave, your PR interval, and your QRS, and that's what you are looking for on your ECG rhythms, and then you would have to measure them. And if your PR interval, you want it to be 0.20 or less, your QRS is 0.12 or less, and from there we will decide what kind of rhythm we are seeing. So again, this is just going to require a lot of practice. We're going through a lot of rhythms today, but we will be testing on the basic ones. So again, you guys will get this, and this is something that if you really think you like, you may want to get into a cardiac type of field like telemetry, or at a cardiac office or something, to where you're dealing with these types of rhythms all the time. So there is 6 basic steps for rhythm interpretation. I'm going to print this out and give it to you guys in class also. So because I recommend that you have this with you, because this is, if you go through this every single time, you should be able to interpret your basic dysrhythmias. So your rate, what you're doing is calculating the heart rate. Remember, there is a 6-second strip. You count your QRSs and you multiply that by 10, and then that will give you your rhythm. Your rate. So if there's 6 QRSs in there, 6 times 10, it would be on an average about 60 beats per minute. Or if they're on the monitor, that's even better. I mean, there are some rhythms that the monitor may pick up, a heart rhythm that is inaccurate, but you can usually tell when you're looking at that rhythm that, okay, that is not a true reading of the heart rate. But for all intents and purposes, most heart rates, they will have an accurate rhythm on the monitor. Okay, and then the regularity. You're going to measure the regularity of the rhythm of the R waves. So is it regular? So your QRS waves, you got your Q, your R is up at the top, and you're going to take calipers and you're going to march them across from each R wave to R wave and see, is the rhythm regular or irregular? Once you determine if that's regular or irregular, you then look at your P waves. And then you want to make sure there's one P wave before each QRS complex. The P waves we're checking, they should be upright in lead 2. And do they look uniform in shape? Is there a P before every QRS? These are things that we are looking for. Okay, then you have got your PR interval. And again, your PR interval should measure between 0.12 to 0.20. And then are all the PR intervals the same or do they change? Okay. And then your QRS width. Remember that should be equal or less than 0.12 seconds. And do the QRSs occur regularly? Okay. And from that, you will be able to interpret your rhythm. Just remember, a normal rhythm shows one P wave that precedes every QRS complex. When this happens, this indicates that all depolarization is initiated at the SA node. QRS complexes without a P wave indicate a different source of initiation of depolarization. So again, if a normal rhythm has one P wave before every QRS complex, it indicates all depolarization is initiated at the SA node. If you have a QRS without a P wave, that means somewhere else depolarization is being initiated. So that's somewhere in the heart other than the SA node. Okay, so now we're going to walk through these step by step. Step 1 is your rate. This ECG paper is a grid where time is measured along the horizontal axis. Each small square is 1 millimeter in length and represents 0.04 seconds. Each larger square is 5 millimeters in length and represents 0.20 seconds. And again, we got that larger diagram that blows up one of those large boxes for you to see. The heart rate can be easily calculated from the ECG strip. This method can be used with an irregular rhythm to estimate the rate. Count the number of R waves. Okay, sorry. This method can be used with an irregular rhythm to estimate the rate. Count the number of R waves in a 6-second strip and multiply by 10. For example, if there are 7 R waves in a 6-second strip, the heart rate is 70. 7 R waves times 10 equals 70. Let's say this, I know it says 3 seconds on top, but let's say this is a 6-second strip. If you count your R waves, you got 1 here, 1, 2, 3, 4, 5. 5 times 10 is 50. So if this was a 6-second strip, the heart rate would be approximately 50 beats per minute. Okay, step 2, regular. Okay, is this rhythm regular or irregular? So if you look at the top one, again, you're going to have calipers to march this out so you can see if they are the same distance apart. But if you look at each R wave, which is at the very top here, you've got 1, 2, 3, 4, 5, 6, 7, 8. Those, just by eyeballing, to me, look regular. I mean, I would call that a regular rate without even measuring out. But you being new, I would recommend you marching them out just to make sure. Okay, and this actually says there's a heart rate of 86. So if we just do the 10-second rule like that, you go 1, 2, 3, 4, 5, 6, 7, 8. 8 times 10 is 80. So that's a little bit off, but it still gives us an idea about where their heart rate is. Okay, so looking at your second one, the regular irregularity, you'll see there's 1 R wave, and then there's 1 R wave that goes down low. This is actually like a PVC. Don't need to know this right now, but you can see a pattern here where you got 1 R wave up, 1 R wave down, 1 R wave up, 1 R wave down. And if you march them out, if you do your R wave to R wave here, to here, to here, that's regular. And if you do the R waves down below, those are regular. So that's a regular irregularity. The third one, if you're marching out the R waves, looks like they're all even. And then up, looks like we've got like a PVC here. That's considered an ectopic beat. So this really is a regular rhythm with 1 ectopic beat in it. Okay, and then the last one, you can't really see any P waves on this. This actually is an AFib. Don't worry about it. You'll learn that in third semester. But when you're marching out the R waves, I think you could see that as you march them, they would not match up as far as same distance apart. So that's considered grossly irregular. Okay, so step 3, presence of P waves. Again, we want to look and see in lead 2, your P waves should be upright. So this, if you're looking, I see 2 upright P waves. You can see the one to the very right that's circled and the one right before that. Then here there might be one, it's kind of hard to distinguish. There's one that's lower, but really you're looking to see, are there P waves? Are they all upright in lead 2? Are they all uniform in shape? Do they all look the same? Okay. And does the P occur regularly? Is there a P wave before every QRS complex? And you're going to say yes or no. For like this type of strip, you're not going to get something like this through this class, which is good. Really what you're going to be looking for is those normal looking P waves, which is on the far right hand of the strip. Okay, then we've got our PR intervals. Again, PR intervals, your normals measures 0.12 to 0.20. So you're going to the beginning of your P wave to the beginning of your Q wave, okay? And then what you're going to do is see how far it is. Does it measure between 0.12 and 0.20? And are all the intervals the same for each one, or are they different? This looks same to me. And if I'm measuring it out, it looks like there's 1, 2, 3, 4. 4 small boxes. 4 times 0.04 is 0.16. So the PR interval is normal at a 0.16. And then your QRS waves, you got 1, 2, 3, 4. If this is a 6-second strip, 4 times 10 is 40. So that would be sinus bradycardia, which we will go through in a minute. But really you're looking at the width of the PR intervals, and then are they same or do they change? And then here's your QRS complexes. Remember, your QRS complexes have to be 0.12 or less to be considered normal. So you're measuring those out. And again, do they occur regularly? So again, we're looking at these and they all look pretty much the same to me. And then you would march them out and then you would measure them. And this, it looks like there's the bottom of your QR. Looks like it's like 0.08 or maybe 0.10. So the QRS complexes in these is within normal limits. So then rhythm analysis, what is it? What is it? We're going to figure that out soon, and we're going to practice in class with lots of strips. Okay, so that way you will feel more comfortable with this. Alrighty, so here's our different rhythm analysis. Normal sinus rhythm. Okay, this is what I hope we all have as we're sitting here listening to this lecture. Normal sinus rhythm. This is showing that the dominant pace or function is from the SA node. So this is in a nice healthy individual that's firing at a rate between 60 to 100 times per minute. All of the conduction pathways are working normally. So salient feature, sinus rhythm is 60 to 100 beats per minute. So again, we're looking for a P wave before every QRS. Each P wave, PR interval, is 0.20 or less. Each QRS is 0.12 or less. And that is your sinus rhythm. Sinus bradycardia. This is where your sinus node is firing regularly at a rate of less than 60 beats per minute. Again, so less than 60 beats per minute is considered a bradycardia. If there's a P wave, we know that it's firing in the SA node, and so it's a sinus bradycardia. So possible causes of sinus bradycardia, increased vagal or parasympathetic tone. So if you are vomiting or you have a carotid sinus massage, something like that can actually make your heart rate go down. Also, the Valsalva maneuver. I'm sure you guys probably know what that is, but that's like if you are bearing down while having a bowel movement, that's called a Valsalva maneuver, and that also will have your heart rate slow down. We get calls all the time in the ED of elderly people that were sitting on a toilet and they had a syncopal episode. They passed out. And when we work them up, if everything comes back negative, we say they probably had a vasovagal reaction, which is they did that Valsalva maneuver, and they slowed their heart down so much that they passed out momentarily. So anyways, that's just a good thing to know. Other possible causes could be a side effect from DIG, right? Because we are always checking the apical heart rate before we give digoxin to our patients. And remember, if it's less than 60 for most, that's when we would hold it. Another possible cause is an athlete. You know, if our heart is conditioned so well that we are working out all the time and doing great cardio, our heart rate may not need to go that fast to perfuse through our body. You know, so those are some lucky ducks right there. But you need to know that if you see someone that has maybe a heart rate of 52 and they're asymptomatic, I ask them, I'm like, what does your heart normally run? And most athletes have been told sometime in their life that, yeah, my heart rate runs slower. So then you can kind of be like, okay, this probably is just normal for that patient. Lyme disease can also possibly cause sinus bradycardia. So care, what do we do? You know, we're the nurse. What are we going to do for them? So we're going to observe for symptoms of bradycardia. They could have shortness of breath. They could have fatigue. They could have the blackouts, you know, the syncopal episodes. They could have lightheadedness and confusion. So if they are symptomatic, we usually give them oxygen. If they are really symptomatic and their heart rate is really slow, many times we will give atropine because that will help increase your heart rate. And if that does not work, we would do transcutaneous pacing, where we will place the big pads on their chest and electrically pace their heart and kind of override it and make it go faster. You know, so that's kind of painful because it's kind of shocking the patient every single beat. So for something like that, we do want to help them out and medicate them so they are not having that much pain. So anyways, that's sinus bradycardia. Here's a slide of it right here. So again, sinus bradycardia, remember, rate less than 60. If you look, we've got a P wave. There's a P wave, P wave, P wave, P wave. Then use your QRS. There's another one, QRS, QRS, QRS. If we're just counting, like this is a 6-second strip, we got 1, 2, 3, 4, 5 QRSs. 5 times 10 is 50. So 50 beats per minute is considered sinus bradycardia. Alrighty, sinus tachycardia. Sinus tachycardia is a rapid rate of discharge of the SA node. So this is greater than 100 beats per minute. The remainder of the conduction will follow the normal pathway though. So you will see a P wave and a QRS wave for sinus tachycardia. It's just going to be going greater than 100 beats per minute. Sinus tachycardia runs at a rate of 100 to 160 beats per minute generally. And possible causes, there can be a normal cardiac response to demands for increased oxygen and need during, like, if they have pain, right? You see your patient's heart rate go up sometimes. They have a fever. If they're stressed. You guys may be having a little tachycardia listening to this lecture going, oh my gosh, what are we getting into here? But it's okay. Do some nice, calm, deep breathing and bring your heart rate down because you will get this. Other causes of tachycardia could include dehydration. You know, if you have a volume deficit in your body, you've got possibly less blood that is supplying oxygen to your organs, so your heart's going to beat faster to try to compensate for that and get that volume throughout your body. Oh, normal exercise, right? Exercise, our heart rate goes up. Okay, so not everything is bad when we're tachycardic. Caffeine and nicotine can make your heart rate go up. Those energy drinks, be careful guys. I know some of you drink those and some of you probably drink too many, but that can really cause some tachycardia. And sometimes after a heart attack or early signs of heart failure, you will also see sinus tachycardia. So how do we care for these patients? If they're symptomatic, if you're having that much tachycardia and they're having symptomatic, they could be telling you they have chest pain. Because again, this is increasing your myocardial workload and oxygen demand. Okay, so if they have chest pain, we need obviously to treat this. So we need to treat the underlying cause. So are they dehydrated? Are they in pain? Are they stressed? Do we just need to kind of talk them down? But we need to treat the underlying cause, and then hopefully that will reverse the effects. Other things that can cause or that can help treating the underlying cause, we can give a beta blocker that can actually slow the heart rate. So stuff like that we can do also. So yeah, just know, treat the cause. A lot of times symptoms, if they're having a lot of tachycardia, they will be complaining of chest pain, so we need to understand that's because their heart's beating fast and it's going in overload, so we need to help treat their cause to slow it down. All right, guys, so those are your sinus rhythms that we are going through. Oh, here's a picture, sinus tachycardia. Again, the rate is 100 to 160 beats per minute. If this is a 6-second strip, I'm going to count these QRS is right here. And we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 times 10, 120. So this is an approximate 120 beat per minute strip that we're looking at. See? Easy. You guys got this. Okay. Now, atrioventricular blocks. I'm going to go through these, but these can be very confusing. I just want to introduce you guys to this. I don't even think I'm going to put anything on the exam with them, so don't start having sinus tachycardia and palpitations now, because again, there are nurses still that get these screwed up, okay? But I want you to at least be like, oh, okay, I do remember Yana saying something about this. Okay, so atrioventricular blocks is if depolarization and repolarization are slow in your AV node. It can make the area vulnerable to blocks in conduction. So when an impulse conduction from the atria to the ventricles is delayed, so for some reason your atrium is not conducting to the ventricle, or it's interrupted because of a transient or permanent anatomic or functional impairment, the resulting dysrhythmia is called an AV block. Okay, so what the heck does that mean? We're going to go through these step by step so that you can understand these a little bit better. All right, so first degree AV block. This is the delay caused by first degree AV block that prolongs the PR interval. Now remember, a normal PR interval is 0.20 or less. In a first degree AV block, we are still conducting, but it's just paused. So your PR interval, when you're measuring your PR interval, it is going to be greater than 0.20 seconds. Okay? The PR interval is consistently prolonged the same amount in every cycle, and the PQRST sequence is normal in every cycle too. Okay, so this is going to look exactly like your sinus rhythms, but the PR interval is to be greater than 0.20 seconds. There is a delay in impulse conduction, usually at the level of the AV node. If you look in this diagram here, you've got your SA node, and then you got your AV node, and for some reason there's a delay in there where it's kind of pausing in there and it's taking a little bit longer to get into their ventricles. So despite the name, the SA node impulse is not blocked during first degree AV block. Each sinus impulse is delayed for the same amount of time. Okay, so let me show you here. This is a picture or a strip of first degree AV block. Okay, so the first P wave we can't even see. It's off the strip, right? But you see that first QRS and T. Now if we look at our P wave, the next one, if you actually measure the beginning of the P wave, the beginning of the Q wave, you don't have calipers, but can you see that's bigger than one large box? So you already know that's greater than 0.20 seconds. But if you measured it out from there to there, then you look at your next one. If it's the same distance before every QRS, and it's greater than 0.20, that's considered a first degree block. Okay, so there's just a delay. The heart is still beating good, but for some reason in the conduction system there's a slight delay. Okay, so that's first degree AV block. All right, second degree AV block. Some impulses reach and others are blocked from reaching the ventricles. Okay, because the SA node is generating impulses in a normal manner, each P wave will occur at a regular interval across the rhythm strip, although not every P wave will have a QRS complex. So the PR interval will vary. Okay, this suggests that the atria is being depolarized normally, but not every impulse is being conducted to the ventricles. So you're going to see more P waves than QRS complexes on an ECG rhythm. And if I didn't confuse you enough as it is, there are two second degree AV blocks. We've got type 1 and type 2. Okay. Second degree type 1, also known as Wenckebach. I'm assuming that is the dude who discovered this. This is a progressive lengthening of your PR interval until the final P wave is totally blocked in the AV node. Okay. Atrial impulses arrive earlier and earlier during the relative refractory period of the AV node until an impulse arriving during an absolute refractory period and appears on the ECG as a P wave with no QRS complex after it. Okay, so again, with second degree type 1, there are more P waves than QRS complexes. Your P waves, when you're measuring your PR interval, they are going to be smaller, then they get a little bit bigger, a little bit bigger, a little bit bigger, until there is no QRS at all. Then it starts over again. So it's just kind of marching them out, and you're getting larger, 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 drop a QRS. Causes, this could be just an athlete that can have something like this, aortic valve disease, some meds like beta blockers, digoxin, diltiazem, verapamil, mitral valve prolapse. These can cause this, but they're usually asymptomatic. If we see somebody in a second degree type 1 AV block, we'll usually kind of keep an eye on them for a little bit, but most of the time they don't come in because they have that, because they are asymptomatic, because they are still conducting quite well. They're just skipping a ventricular beat every now and then. So here's a picture of your second degree type 1 block. All right, so top one, got these nice little arrows here for you, but you've got your P wave. So if you looked at your PR interval, this one's pretty big. I think you could even see the beginning of the P wave, you got 1, 2, 3, 4, maybe a little bit over 4 boxes. So 4 times 0.4 is 0.16 is your first PR interval. Then look at the next one. We've got 1, 2, 3, 4, 5, your PR interval. The second one is 5, so it's 0.20. Then look at your next P wave. 1, 2, 3, 4, 5, 6. 6 times 0.4 is 0.24. Okay, so as you see, it's kind of smaller, getting larger, larger, and then your next P wave, there's no QRS. It just dropped it, and then it starts over again. So that's a progressive lengthening of your PR interval, and then it drops a beat with your QRS. If you look at the strip below, same thing. You can see your P wave, your PR interval, and if you measure that out, then you measure the next one. I think just even eyeballing it, you can see that the next PR interval is even bigger, and the next one is even bigger. Then your next P wave, there's no QRS. And it starts over again. PR interval, then your PR interval is larger and larger and drop. So that is a second degree type 1 AV block. Second degree type 2, which is also considered Mobitz is the name. So that must have been Mr. Mobitz or Mrs. Mobitz who figured this out. Second degree type 2 usually occurs below the AV node. This is less common in type 1, and type 2 is more serious and is a cause for concern because it has a greater potential to progress to a third degree AV block. It can have block of Purkinje fiber bundles, and it blocks a number of paced atrial depolarizations, which is your P waves, before conduction is successful to the ventricles. It may produce a 2-to-1 or 3-to-1 or higher. What does that mean? You'll see 2 P waves to every 1 QRS or 3 P waves to 1 QRS. So you'll hear 2-to-1 or 3-to-1. With Mobitz, which is your type 2, every cycle that's missing its QRS has a regular punctual P wave, never a premature P wave. The PR intervals are the same distance, and then a P wave suddenly appears with no QRS after it. When the PR intervals measure the same, they are constant or fixed, is how we say they are. This is caused by disease of the left coronary artery, acute myocarditis, aortic valve disease. Those are some of the reasons. If the ventricular rate is within normal limits, your client may be asymptomatic, although they should be monitored because it could progress to a 3rd-degree AV block. All right, so let me show you a picture of this so you can be like, what the heck are you talking about? This is 2nd-degree type 2. So if we're looking at our P wave, your PR interval, okay, you can see there, it looks like it's 1, 2, 3, a little over 4, so 4 times 4 is 0.16. And then the next P wave, it dropped to QRS, right? But then this one, you've got your PR interval is the same. It's 1, 2, 3, 4, and it dropped. So your P waves stay the same in 2nd-degree type 2. In type 1, they get a little bit bigger, bigger, and then you drop the QRS. For 2nd-degree type 2, you've got your P waves that are constant, PR intervals are constant, and then it drops. If you look on the bottom strip, same thing. You've got your PR interval, and then your next P wave, it looks like it dropped. Then look at this. You've got a PR interval here. You measure a PR interval. The next one. Those are all the same, and then it drops. So remember, you're counting how many P waves. If you look at this bottom one, we've got 1, 2, 3, 4. So it's a 4-to-1 type 2 on that bottom strip because you got 4 P waves, for every, that you're counting until you get a QRS that drops. For this top one, you've got 1 P wave, 2 P waves. So this is a 2-to-1 type 2 Mobitz on the top one for you. So again, we will practice these. Again, I'm just introducing you to this. You're not going to be having this at this point on an exam, but if you want to become an ECG guru, you are going to have to learn this at some point. All right, our last type of block is our 3rd-degree AV block. So 2nd-degree AV blocks are an incomplete. For some reason there's like a delay in something on there, but it's not a true block because we are still getting conduction through the heart. 3rd-degree AV blocks are actually complete heart blocks. Okay, these are bad. We do not want to have these. So again, 2nd-degree AV blocks are types of incomplete blocks because at least some of the impulses from the SA node are conducted to the ventricles. With 3rd-degree AV block, there is a complete block in the conduction of impulses between the atria and the ventricles. Okay, what does that mean? It means none of the impulses will reach your ventricles, which completely blocks the conduction of your atrial stimuli to the ventricles. So your ventricular rate will be regular. Your atrial rate is regular. So your P waves will plot through. You'll march them through, but there's no relationship between the atrial and the ventricular rhythms. The ventricular rate is determined by the origin of the escape pacemaker, and the atrial rate is greater and independent of the ventricular rate. So what's an escape pacemaker? Remember, your SA node is your primary pacemaker of the heart. Then it goes down to the AV junction, and it goes down into the right and left bundle branches, Purkinje fibers. So your heart blocks, for your escape pacemakers, usually in those Purkinje fibers. So these heart rates are slow. They're usually between 20 to 40 beats per minute when you're looking at your QRSs, right? Your ventricular contractions that are going on. That is usually normal in size and shape, but again, there's not a P wave that follows a QR or is followed by a QRS complex, and there's no PR interval really. The atria and ventricles beat independently of each other. All right, let me show you what a 3rd-degree heart block looks like. Again, there's no conducted beats, slow ventricular rate. So if you look at that first one, there's a QRS there. So let's look at our QRSs. If you march out your QRS to QRS, they are usually pretty regular. Okay, so your ventricles are firing and they're going slow, but they're, that backup pacemaker function, escape pacemaker is, making it at least beat. But then look at your P waves. You got one P wave here, there's no QRS. You got a P wave here, there's a QRS, there's a P wave. There's like no relationship. So if you march out your P waves, those will be equal also. But again, there's no relation to the QRSs. And again, these are slow. Okay, so this is a medical emergency. This gets our attention if we find out that somebody is in a 3rd degree heart block. Okay, let's look at another picture. Here's another one. So look at the little green arrows. It's showing where your P waves are. So you've got your P wave. If you march it to your next P wave, march it to your next and next. And actually the next one is like hidden in your QRS. But if you went on to the next one, it would keep marching on. So the P waves are equal in distance apart. But again, then you look at your QRSs and there's less of them. It's a slower rate. And they march out on their own. But again, there's no relation between your P waves and your QRSs. This might help you a little bit. I found this online. So 3rd degree heart block is a blockage at or below your AV node, which you can see in a diagram there where your AV node is. It cuts off any signals from getting to your ventricles, which will cause the ventricles to initiate an escape rhythm. So if you look at that top little part of the heart where it has the SA node talking, it says, hey ventricles, what's going on with you guys? I'm only pacing into atria, right? So it's beating, it's contracting, and that's your P wave that you're seeing, but it's not getting through to your ventricles. And your ventricles, another one is saying, I can't hear you, I'm busy down here pacing myself. Because the ventricles are like, oh shoot, for some reason we're not contracting, so we need to do this. So that's why, again, you've got that escape rhythm pacemaker, and that's why it is going so slow. There's one more. I thought this was kind of cute. So again, the P waves and QRS complexes are completely independent. The dissociation between the atria and ventricles result in 2 separate rhythms superimposed on the EKG. So if you look on the bottom here with the blue, you've got your QRS, and I actually have a little P wave down here on the bottom, and then a P wave, P wave. So if you march those P waves out, they all are regular, as far as the distance apart, and so are your QRSs, but again, there is no relation between the atria and the ventricles. Okay, so we'll talk about this in class. So hopefully at least you get the basics with it. Again, this is a lot of information you're getting, and I'm going to concentrate more on the more common things that you'll see. And again, when you decide you want to specialize in something like this, you will get really good at it. Okay, so here in just a summary, your atrioventricular blocks, your 1st degree heart block, there is a delay, and the PR interval has a prolongation, so it's greater than 0.20 seconds. But remember, it's greater than 0.20 seconds, but it's all the same. Your 2nd degree, remember this is the disease of the electrical conduction system. So type 1 is a progressive lengthening of the PR interval until the beat is dropped. And your type 2 is a constant PR interval before the dropped beat. And this is a lower focus in the heart, so that's why type 2 can sometimes progress into your 3rd degree heart block, where there's no conducted beats, there's a slow ventricular rhythm, and there's not a P wave in front of every QRS. It prevents sinus-paced atrial depolarization from reaching the ventricles. So just kind of remember that for 2nd and 3rd degree blocks, when a QRS complex is not preceded by a P wave, your ventricular and atrial depolarization are initiated from different sites, right? They're not all coming right from the SA node. Your ventricular and atrial depolarization are initiated from different sites in your heart. All right. So what do we do? These heart blocks, what do we do? So we're going to observe them. We're going to observe for lengthening PR intervals or development of more serious heart blocks, collaborative care, you want to treat the cause. So if it's a drug toxicity from like digoxin, beta blockers, calcium channel blockers, antiarrhythmic agents, we're going to treat that. If they have an electrolyte imbalance, like the potassium's off, we would treat that. Again, if it's a third-degree heart block, this is considered a medical emergency. Most of these patients are about to have a heart attack. That's kind of what it's turning into. For your first-degree heart block, as far as care, it's usually unnecessary. Usually the heart rate's normal and your patients are asymptomatic. Second-degree heart blocks, if they're not symptomatic, we usually don't treat, but we will watch. If they are symptomatic, we'll do the oxygen. If they're bradycardic, we'll give that atropine, or we may do that transcutaneous pacing that I mentioned before. Third-degree heart block, we do the same treatment, the oxygen, the atropine, and then we trace. If they're in third-degree heart block, you need to check their level of consciousness too, because their perfusion may not be adequate. So they will have inadequate cerebral perfusion, right? So they could be confused or maybe, hard to arouse. So again, you need to check their LOC if they're in third-degree heart block to make sure they're at least perfusing enough blood and oxygen to, reach their brain and their organs. So just, remember that is good to know with third-degree heart block. All right, guys, only a couple more, then we're done. I know you got to be so excited, but done with the blocks. Ventricular dysrhythmias. So ventricular dysrhythmias, as the name says, it is originating in the ventricles. Okay. Your QRS can be greater than 0.12 seconds because something's going on with the conduction in the ventricles. They can be very dangerous, some of these ventricular dysrhythmias. It could trigger like a ventricular tachycardia or ventricular fibrillation. We can lose our atrial kick, which means we're not using the atrium, and the heart's efficiency is greatly reduced. All right, so let's go through these. We got premature ventricular contractions, which are also known as PVCs. The description of this is an ectopic or abnormal beat originating from an irritable cluster of cells in a right or left ventricle before the next expected sinus beat, which is premature. The QRS is wide and bizarre looking. So if you look at this little strip down here, you've got your P wave, then your QRS, and you got like this really this wide and bizarre QRS. That is a PVC, because if you were marching them out, you would think that, okay, we need a little bit longer before we would start having that contraction again. So yeah, you've got your sinus rhythm right here with a PVC is what we're looking at. There are different types of premature ventricular contractions, or PVCs. This looks complicated, but actually it's not too bad. A unifocal PVC is just a single focus or one area. So you will see just an occasional unifocal PVC. So you'll see sinus beat, PVC, sinus beat, okay? Smokers are at risk for PVCs. So another reason not to smoke if you do. Multifocal PVCs means that there are several different ventricular focuses, so there's a greater irritability. So the ventricles, they could be firing in different areas of the ventricles, so your PVCs may not look exactly the same. And these are more dangerous, okay, because the more PVCs we have, those can turn into something else, which I'm going to talk about in a minute. If you see two PVCs together, that's called a couplet. Ventricular bigeminy is like every other beat. So this exists when normal complexes and premature complexes occur alternately in a repetitive two-beat pattern with a pause occurring after each premature complex, so the complexes occur in pairs. Ventricular trigeminy is every third beat is a PVC. Ventricular quadrigeminy is every fourth beat. So I think you get the picture here. There is also something called an R on T phenomenon. This is where an early ventricular beat at this time could put the heart into a ventricular tachycardia. So this is something I think you will go into more detail in fourth semester. But if they have an R on T phenomenon, that's not good because you could be putting into a fatal heart rhythm. Let's see here. Okay, so here is a picture of another PVC. Again, I think hopefully you guys can see it, even if you're, just looking at this for the first time. You've got your normal PQRS, 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 and oh, here's this wide, bizarre QRS. That's your PVC, and it goes back to two normal PQRSs. Again, it's a bizarre premature QRS. The QRS is greater than 0.12 seconds. It's a compensatory pause, and your P wave may be lost. Because it was early, the P wave is kind of hidden in here, so you don't always see a P wave before a PVC. Here is some pictures of some that we were just talking about, unifocal and multifocal PVCs. So this one, you can see there's a PVC here. This actually, you go 1, 2, 3, 4. This is actually a 4-to-1. You could say actually a PVC on the top one, a 4-to-1, or multifocal, because there are several different, PVCs that are firing. The second strip, I think you can see there is one PVC, so that would be like a unifocal. And on the bottom, here's a trigemini. You got 1, 2, and then PVC, 1, 2, PVC, 1, 2, PVC. Okay, so that's considered trigemini. So what causes these? This is just something that may help you remember. Hank and Harry have depressed, enlarged hearts. So hypoxemia can cause PVCs, acidosis, hypokalemia, hypocalcemia, drugs like digoxin, epinephrine, which includes stress, emotions, fever, and in hearts is like hypomagnesemia. Those are all possible causes. Also caffeine, tobacco, alcohol, so that could also be, in epinephrine as far as stimulants are concerned. Oh, here we are, caffeine, tobacco, and alcohol. So you guys may feel PVC sometimes, especially if you do drink a lot of caffeine. I hope you don't smoke, and be safe if you drink alcohol, but if usually that's for someone that is more of an alcoholic that would start feeling PVCs. But the caffeine, I felt them before, so you just got to kind of watch it, if you don't want to feel too many of those. So collaborative care, if they're asymptomatic, we rule out like hypoxemia and hypokalemia. If they have hypoxemia, give them oxygen, right? Hypokalemia, we draw labs, so they may need some potassium. If they're symptomatic, in acute myocardial infarction, PVCs indicate a need to aggressively treat the ischemia or infarction. So if they're having an acute MI or heart attack, they would need oxygen, nitrogen, morphine, and potentially some antiarrhythmic agents. Okay, so those are just some things that we need to be aware of. Now, if you see somebody and they're complaining because they have PVCs and you're going to discharge them, it's important for you to educate clients to stop smoking, stop doing illicit drugs, drink alcohol in moderation. This is an easy one, decrease stress. I'm sure that's real easy for you guys right now, but decrease stress and educate regarding adverse effects of medications if that is one that causes the PVCs. You also want to educate to keep a current medication reconciliation for future healthcare providers to review. If the patients are going home with a home health, like nurse coming, it's important to report the med rec to the home health nurse. Okay, so some of you, they'll be working on the floors. Many times with discharge, social work gets involved and there will be a home health nurse. So it's important that you make sure that that home health nurse has a current med rec or knows what that patient is currently on. Okay, so education and those med recs are so important now. Just remember that when you go from one area to another, if you're getting discharged or getting admitted, that med reconciliation is really important to just improve the, a better outcome for your patient. Okay, yeah, I already said this, but educate your client to stop smoking, drink in moderation, decrease stress, and again, no side effects of potential meds. So yeah, that's your collaborative care. So it's really important that you do all of that. All right. Ventricular tachycardia. This is described as 3 or more PVCs in a row, and it's a rate greater than 100 beats per minute. Usually the rate is between 100 to 250 beats per minute. The QRSs are usually wider and bizarre, and it's greater than 0.12 seconds. So this is a ventricular tachycardia that you're looking at here. And we don't even count it. If we see something like that, we're like, oh my gosh, okay, let's see what's going on here. What do you think you want to check with this patient? Okay, you want to see if they have a pulse. Okay, because some ventricular tachycardias can have a pulse and others do not. So we need to verify that because that will determine what type of treatment you do. So check, is there a pulse? Your best place to check for a pulse is either your carotid, or if they're in a hospital bed, you can even go for the femoral, because sometimes it's hard to feel a carotid. So some will go to femoral, but usually carotid is easy. And then look at your patient, okay? Assess them first. Are their ABCs intact? Look at your client. They may be looking at you like, what's wrong with you? It just may be some weird thing where the leads are put on wrong, or they're moving, or something. I mean, that's probably not, but you always want to just make sure. Look at your client first. You're not treating the monitor, you're treating your client. Check your leads. Again, make sure the leads are all connected, they're in the right place. Drug toxicity is a big one that we see in the ED. Have been taking meth or cocaine. Those can cause heart irregularities that can put them in these ventricular dysrhythmias. And electrolytes. Electrolyte imbalances can also do this. So regardless, if they're in ventricular tachycardia and you assess them and they are in true VTach, put them on oxygen. You need an IV access. If there is not a pulse, you will begin CPR. Okay. Then there's ACLS protocol, which at some point in your career you probably will do, but we will prepare for synchronized cardioversion or defibrillation, depending on if there's a pulse or not. And then we give epinephrine, vasopressin, amiodarone, lidocaine. There's different antidysrhythmics that we will give depending on what's going on with your patient. You do not need to know that. Just again, remember your ABCs. I always tell you guys that, and look at your client. Don't just look at that monitor and jump to conclusions. And then a lot of times, the lead could be off or misplaced, so you want to make sure those are correct. And then drug toxicity is a big one, and electrolyte imbalances. All right, ventricular fibrillation. This is no organized ventricular depolarization. So imagine shaking a bowl full of Jello, and that is your ventricles that are going on. The patient does not have a pulse, does not have cardiac output, or a blood pressure. Okay, these patients are unconscious. Coarse VFib, the fibrillatory waves are more easily seen and are usually more easily converted by prompt defibrillation. So when they're looking like they're a little bit rockier and there's more going on, it's a earlier VFib that you caught them in. So if you shock them out of it, you have a better chance of shocking out of them. When you see fine VFib, it looks a little bit like asystole, and it's more difficult to have a successful resuscitation because, again, their heart is actually kind of going to where it's about to stop. So here is pictures of ventricular fibrillation. The top one is like a fine VFib, and the one below is a coarse VFib. Okay, if you look at the bottom one with the coarse VFib, remember with your ventricular tachycardia, your QRSs are wide and bizarre, but they're all pretty much the same. Where if you look at this with the fibrillation, again, think of a bowl of Jello just shaking, and that's kind of what those ventricles are doing. So that's why it looks like this. So there is no uniform way. It's just very chaotic, and there is no discernible rhythm. So collaborative care, CPR. Again, these patients will be apneic, pulseless, and unresponsive. So what you need to do is start compressions immediately. Okay? Before anything else, get on that chest and start compressions and yell for help. Begin CPR. And then we have ACLS protocol, which again, you guys don't need to memorize. But you will be preparing to defibrillate. So if you are on like a med-surg floor, you would call a code, you would get the monitor and put them on the pads, and then prepare for defibrillation. So when they get up there, they will defibrillate this patient. So you need to make sure when someone is about to shock that patient or defibrillate them, that everybody is clear. And I'm sure you guys have seen it in the movie, you know, it says, I'm clear, you're clear, we're all clear. Because if you're leaning up against that bed and they push that shock button, guess what? You're going to get shocked too. So you need to make sure no one's touching the patient or no one's touching the bed that they're in. And then we go through the ACLS drugs with epinephrine, vasopressin, amiodarone, and lidocaine, depending on what's going on. Okay? Last one, guys. This is probably how you feel right now after this lecture. Asystole. This is where there's an absence of electrical activity and there is no ventricular contraction. So you'll see a straight line or, you know, kind of a wavy like that on your ECG. You know, and that's kind of what asystole is.